Oi, oi, oi. Ainda é bom dia, né? Ninguém almoçou,
Hello.
nem eu.
Still good morning. No one had lunch. So good morning, everyone. Thank you very much once again. I'm back here to talk about a different topic now. And I would like to tell you that we needed to make a small change in our table, our round table, because one of the speakers couldn't be here, Andre. So you're not going to have the pleasure of hearing from Andre today. But I prepared a presentation with the results of a paper by ITpS. I'm not going to be as good as Andre, but I hope to bring you some interesting news. The title of this session is Febrile Syndromes in Brazil. And this table is actually an invitation to everyone who is an expert in malaria to think outside the box. A problem that uh, uh, this is a problem that goes beyond malaria. So I would like to invite two fantastic people today that are my friends and have an amazing resume. I would like to invite first Professor Tania Chaves, an infectologist, researcher in public health at the Evandro Chagas Institute, professor of FAMED, UFPA, and CESUPA. She's the coordinator of the group of orientation to the center of orientation to the traveler, and she's also my friend.
Bom, eu queria convidar também uma outra mulher
I would
poderosa,
also like to invite another fantastic, powerful woman,
que é a Aniele Pina.
Aniele Pina. She is the master and doctor in infectious diseases. She has a postdoc in tropical medicine. She is the professor of infectious diseases at the Fluminense Federal University and researcher at the outpatient clinic of acute febrile diseases of IME. I asked them to send me a nanobio because they have great big CVs. So I'm going to break protocol and I'm going to start instead of letting the girls start. But I excused myself to them. I asked their permission, so I'm going to be doing the first presentation. And I'm going to speak about a project of ITpS, but before I talk about this project, I have to talk about what is the Institute Todos pela Saúde. This roundtable was suggested by us for this event, and I would like to make a small advertisement about our institute. And I'm going to show you a video. It's going to take 2 minutes of your time to tell you a little bit about our story.
Quando a vida que você conhecia
When did the life that you know stop? In 2020, unfortunately, we had to deal with a reality that was unimaginable, a pandemic. Sick people, empty cities, full hospitals, distancing, new routines, fear. What about the future? What will be of the following days? Brazil was facing that virus that was unknown in the correct manner. In this doubtful scenario, there was the initiative Todos pela Saúde with a donation of 1 billion reais made by Itaú Unibanco. Every day, a group of renowned experts in Brazilian public health would gather to help Brazil face COVID-19. This money reached where they needed the most: vaccine factories, testing centers, masks and equipment, and assistance to those who need it the most. And we also had the biggest campaign of use of masks in Brazil. In 2021, the campaign was transformed into the Institute Todos pela Saúde, ITpS, a non-for-profit entity that collaborates with Brazil in facing epidemics and pandemics so that we don't have to live again what we experienced during the COVID-19 pandemic. ITpS has a board, a technical advisory board, consultants, and an internal team formed by bioinformatics professionals, data scientists, and researchers in areas like epidemiology, virology, and public health, and also communication professionals. Projects are developed internally with the strategic partners in three fronts: strengthening of epidemiological surveillance networks, data analysis, and information and training. In addition to this, the Institute also has another important mission, which is supporting the creation of a state policy to face emergencies in public health and a center to implement it. This structure must be capable of articulating, preparing, preventing, and responding effectively and sustainably to epidemics and pandemics based on the best scientific evidence. ITpS is much more than its name. It's a commitment to the future of Brazilian people because the right to public health is not for some, it's for all.
Bom, hoje no Instituto a gente tem mais
Today
de
at the
duas
Institute, we have over two dozen projects involving different topics. Of course, I'm not going to talk about all of them here because it would take practically a whole day, but we work based on three great pillars, and one of them is the pillar of data analysis. Within this pillar, we have big projects in the area of genomics applied to public health, and I'm going to talk about one of them today. Of course, the Institute wouldn't be what it is without the contribution of these many people that are part of this institution, which is very small, very tight team, but we work through network governance, which makes us more efficient and bigger. We have the administration council, we have the administration board, a technical advisory board that is composed by big names in public health, and we have a team that is now made up of 17 people, including myself and Jason Pena, the directors of the institution, and a group of young and willing researchers that want to change public health in Brazil. This project is called Revisa. It is an acronym, and it is an expanded surveillance network, a surveillance network that thinks beyond the diseases, that thinks about the infections and the pathogens. And this figure probably will appear in many of the presentations, but it is just a demonstration of what we see when we focus only on malaria surveillance. We are above the level of the water. What is below the iceberg, we end up neglecting. So it's almost 90-10. 90% of the infections that cause febrile syndromes in primary healthcare have been ignored. I don't know if you know, but my beginning in the public health 20 years ago started in a malaria program in Manaus, and I used to observe that in the field. We did have a very well established protocol for when the patient arrived there with malaria, but when they were negative for malaria, they were neglected. They would tap the patient on the back and say, unfortunately, I don't know what you have. But this individual had a fever, and the problem comes from that. Today, our surveillance is based on disease, and from the clinical standpoint, that's okay, but from the standpoint of public health, we might be missing a new pathogen or an emergent or re-emergent pathogen. And genomics is a tool that has been very much used for this kind of surveillance. Many will say that this is an expensive technology or method. And I would say that after the COVID-19 pandemic, if there was any kind of legacy, and I am afraid of talking of legacies of the pandemic, is that these technologies became a lot cheaper to the point that we can use them in public health. But today, we have this world of genomics working pretty much in parallel with the universe of public health. We have a distance between the genomics data and the clinical data, and the idea was to approximate these two data so that this technology can be used for public health, in fact. So we stimulated the creation of a small network made up of two centers, one of them in Manaus in the Foundation of Tropical Medicine and the other one at the Federal University of Rio. So we have two different epidemiological scenarios, and they would work as sentinel centers. The main difference here is that we have clinical and laboratory and genomic protocols that are very well established, and the idea was to create a use case, a pilot that could be used and extrapolated in other regions and ultimately incorporated by the universal healthcare system for the surveillance of febrile symptoms using genomics. We have several problems today. This is a very deep problem when we talk about genomics for public health. I'm not going to talk about all the aspects, but we have a problem of governance. And our main problem today is the disintegration of this data, the clinical and epidemiological data, and the genomic data. These are the two things that are working in parallel. Our capacity of sequencing in Brazil has been underused because it is based on diseases and not the detection of pathogens more comprehensively. And we think it is possible, but this still does not happen. We think it is possible to implement these techniques in the public health. So we proposed the articulation with these two centers that have outpatient clinics for febrile syndrome so that we can integrate the clinical, laboratory, and genomic data in a way that we can characterize pathogens, different lineages of known pathogens, but also unknown or neglected pathogens. This is the protocol. So the patient enters the outpatient clinic with any kind of febrile syndrome, and we separated the respiratory febrile syndrome in one protocol and the other febrile syndromes in another protocol. And the other protocol has more malaria in the Amazon region, in the southeast region. But we used all the available panels by CG Lab in the LACEN network for arbovirus and for respiratory viruses. We would join all of this in a repository with clinical data, demographic data, and we had a strategy of sequencing, used a product that is made available by Illumina called VSP2. It's a dashboard of metagenomics, but it is enriched by a set of about 200 specific viruses. It is metagenomics, so we can detect any pathogen that left a trace of genetic material there. So our strategy was to test 80% of the samples negative for everything, including malaria, and 20% through Amplicon method for known pathogens. So we want to monitor genetic variations of known pathogens and identify, of course, new pathogens that are emerging or re-emerging or neglected. Obviously, this ends up in a bioinformatics analysis. We have many pipelines involved. The people who work directly with this are in the audience right now, Felipe and Barbara, and they can tell you more details about this. It is not trivial, but the idea is that this whole process in an ideal world should happen in a deadline of 7 days. But we know that we don't live in an ideal world. And our idea is to approximate this time between the beginning of the symptoms and the data being analyzed and appropriately made available for health, for public health in 60 days, which is already a big challenge. So we developed an algorithm for sample selection, understanding that once again, this genomics here is not for individualized treatment. It is not very useful for clinical purposes. It's for public health. We don't need to sequence everyone. That is what the use case brings, the strategy to select the samples that serves the public health. So this selection algorithm takes into consideration the beginning of the symptoms, if the CTA of PCR is appropriate for sequencing. There is a set of criteria that makes this sample more viable for this metagenomics technique. We sequenced until the moment that we analyzed this data 273 sequences. We identified 79 different viruses. Remember that our initial focus was only viruses, but talking throughout these days here, I'm going to give this spoiler. Okay, Felipe searched for the Plasmodium sequence, and he found for Plasmodium vivax and falciparum in the samples. Felipe is here as well. He helps coordinating this project in Manaus, and he can confirm that these are theoretically negative samples for malaria, and the metagenomics showed that this is not the case. I'm not going to talk about each one of these viruses, but in that dashboard that you can see. You can see the type of virus and the absolute number of their identification. The idea is that this genome data is made available publicly immediately so that it is used for public health purposes. And we found a myriad of things, of co-infections, unimaginable co-infections like Epstein-Barr with SARS-CoV-2, hepatitis B with flu B. There's a patient that arrived with respiratory systems, but he had hepatitis. So there's all kinds of things. And this project contributed to the publication of the first genomes of these viruses that are found on this side here. So there are genomes publicly available. It was thanks to this project that is a great contribution as well. This is the concordance rate between PCR and metagenomics. It shows that the accuracy of the method is good, but I would like to show this to you. 77 new findings that were not detected in PCR, but they were detected in metagenomics. And we have a myriad of viruses here as well, all of them with some clinical relevance, and they were detected by this method. I bring one case here. It is a red dot that you can find in the middle of all of those red dots. And just to make it clear, the Ministry of Health was warned, Maria Angela, the Secretary of Surveillance, was alerted, and the local authority of Amazonas was also alerted on this. We understand that we're not necessarily talking about an epidemic or an outbreak of this virus. We found occurrences of this virus called Guaroa virus. It causes clinical disease. This was a 46-year-old male patient seen in Manaus in September with myalgia and other symptoms similar to malaria, and actually this virus was infecting him. It is not a new virus. It has been circulating since the 1970s. The first genome dates back to the 1970s, and what we showed in this phylogenetic analysis is that these viruses have been circulating in the Amazon region for decades without being noticed. But from the clinical standpoint, it might not be relevant, but it is a virus that deserves our attention because it is very close to the endemic areas. As far as we know, with the knowledge that we have so far, it is transmitted by anopheles. So it has something different.
As a part of this project, we have a communication strategy, as with any project. As soon as we became aware of the viruses, we communicated the local health authorities at the local and national level, and we also communicated all of the results that we get. First, of course, to the decision makers, and then to the public at large when it is relevant, which I believe is not the case with this virus. Well, this project, as with any project in ITpS, would not be possible if not for many institutions and hands working together. I would not thank every single one here, but I would just like to make a general word of thanks to everyone who contributed. Thank you so much. As I'm here playing many roles, I would change my hats here and like to invite Professor Tania to make her presentation. Good morning, everybody. I would also like to thank the organizers for the invitation. I was given the challenge to talk about febrile syndromes in the Amazon. Malaria will always be center here, but to bring about this discussion is quite a challenge. Also due to the Amazon features, because of the local biodiversity that we find in that region in terms of agents, the overlap of the urban and forest areas, the local characteristics, and the mobility. So I took the liberty of discussing the febrile syndrome in the Amazon and not as the systematic review of the agents, the etiological agents, but to look beyond the clinic in order to discuss mobility and to get to know this territory better. Yesterday, we were discussing this during the laboratorial panel. Health surveillance is key here, and it has been established how fundamental it is for us to connect these three areas. So febrile syndromes are characterized, as we know, by the presentation of fever equal or greater than 38 degrees Celsius, accompanied by other symptoms. And that can include myalgia, joint pain, and that is also a challenge for clinicians. The infectious agents and the symptoms overlap. This is one of our challenges. This is something that Anderson talked about, and it is quite concerning in clinics. Professor Ivete knows this. The neurological and febrile syndromes. Sometimes patients are hospitalized for a long period of time and we're simply not able to diagnose. And although we have amazing tools, just like the ones that Venderson mentioned, I've been talking about metagenomics a bit more. Although we have so many tools, this is a very important piece of data, and not just from Brazilian studies here led by Professor Patrícia Brasil and Daniele as well. So over 50% of the febrile syndromes observed in these studies and in other studies, they remain undiagnosed. So how much is going through and slipping by, just like Vanderson mentioned as well, a virus that doesn't seem as important, but it is nonetheless unknown. Why these gaps are in place? The limitation of laboratorial panels, the low suspension for the clinical diagnosis, agents that are not as well known, and also within surveillance, surveillance is still centered in priority illnesses. So these are gaps that are also challenges in our daily practice. Already a special word of thanks for Alexander and his team. I was concerned with the number of cases which are negative for malaria and the impact of that. So what do we see here beyond arboviruses and bacteria that we are simply not able to reach? This piece of data is very concerning because of diagnosis lateness. This lateness means that you may maintain transmission on recurrence of aggravation as malaria and underreporting, which is also quite relevant. So myself, as well as many infectologists who work there, usually we ask ourselves, if it's not malaria, then what is it? Although we have a negative result, it may be a low parasitemia malaria. And do we have a PCR available to conduct this diagnosis? Yesterday we mentioned this. Everyone wants to know the diagnosis. We want to know what we have, and the patient families want to know. So if it's not malaria, then what is it? It could be leptospirosis, dengue, the other arboviruses. Maiari Europoshi has expanded very quickly from Roraima. It went beyond the Amazon and it was diffused in record time. And here I call your attention to the importance to mobility.
E antes de entrar neles,
And
também
we talk
chamar
about
a
the
atenção
travelers.
que a síndrome febril é a porta de
The
entrada
febrile syndrome
no
is
sistema de
the
saúde.
gate
E o
in
gargalo,
the health
opa,
system.
vamos voltar. E a gente enfrenta esse gargalo
And we
de
see
novo
this
aqui
bottleneck
pela
once again
sobreposição da
due to
apresentação.
the
Porque
overlap of the
a
clinical
maioria desses agentes
symptoms of most of these infectious
bom, ele
agents.
está insistindo, mas tudo bem. Bom, e isso também é um outro desafio, porque
And this is
nos
another
processos de
challenge.
diagnóstico, nós temos atraso
Misdiagnosis is a risk.
de casos,
This
e aí a
generates
gente
lateness,
precisa,
and
muitos agentes, e principalmente aqui
for
no
many
caso
of
da
these
gente,
agents in here also
agentes
include
respiratórios, né?
the respiratory
Nós
agents,
interromper
the
o mais
respiratory
breve
viruses.
essa transmissão. E nós nos esbarramos
We need to interrupt
novamente
that
nas
transmission as quickly as
ferramentas
possible.
diagnósticas.
And here, once again, we utilize a variety of
E
diagnosis
aí,
tools.
eu queria chamar a atenção, e tenho discutido isso com os colegas, com os
We've
amigos,
been
que a gente
discussing this with our colleagues.
pensar aí, que a síndrome febril na Amazônia é
The
além
febrile
do
syndrome in the Amazon is not merely
conhecer a
clinical. We
epidemiologia
need to know the
do território e
epidemiology,
a
the territory,
característica das
and
pessoas
the
que vivem
features
naqueles
of the people who live in these
que também
locations
são viajantes. É o ribeirinho
and who are
que
also
desloca
travelers. So people who
da
live
sua
by the
zona do
rivers,
município
who move
para
from their
outra localidade do
location
mesmo município e distante,
to
e
move
isso
to other municipalities
significa
for a variety of reasons.
pode
This is
contribuir
important. This
para
is a factor that can
a
contribute
expansão
for
de agentes
the
infecciosos.
expansion of
Então a
infectious
gente
agents.
tem que
And
ter
therefore,
esse olhar
we
para
must
o
have this
hospedeiro,
attention towards the host.
para o hospedeiro, o agente e o território.
The host, the agent, and the
Então, a
territory.
mobilidade, acabei de falar, ela é muito importante.
So mobility, as I just said, it is extremely important. It is a biosensor, so to
Quase
say.
assim,
It is a
devido
marker
nós,
because
né? É a mobilidade humana que é muito rápida, é muito fácil
human
de se
mobility is
deslocar.
very
Ou,
quick.
às vezes,
It's very
falando
easy
isso,
to
as
move around.
apresentações dos colegas que
Sometimes when
trabalham no
I
garimpo,
watch the
muitas
presentations of my
pessoas
colleagues who
chegam,
work
essas
in
áreas são consideradas
in
remotas.
mining,
Eu me pergunto até
these areas are considered remote.
como são remotas,
And I
porque
wonder how
quantas
remote are
pessoas estão
these
ali
areas
e
actually?
em
How many
importância
people are there?
nas, nos
Where do
dados
they come
estatísticos
from?
de
And how are
do
these
agravo, por exemplo, de malária
represented
e
in
zika.
statistics,
Então, aqui é para
especially in malaria
mostrar
studies?
essa
So
mobilidade como
this is an example of the
determinante da
mobility as a
da
determinant
rápida
for the
circulação e
quick
também da
circulation
efetividade.
of
Nós
agents.
observamos na clínica
And this is also
que
something we
muitas
see in
pessoas
clinics.
passam conosco e não continuam o segmento porque precisam
When
retornar
patients don't
para
continue
os seus
because they
destinos.
need to
Então,
return to their
essa,
destinations.
essa matriz de risco
This is a
é
risk
baseada
matrix.
nos cenários
It is
dinâmicos
based on the
que nós
dynamic
temos
scenarios that we have in our
nos
country,
garimpos, os
which are
territórios
mining camps,
indígenas,
indigenous
nos
territories.
garimpos, né? E nos garimpos o que a gente
So
vê
in mining
é
areas
baixo
first,
acesso a
what
essas
we see is low access to
uma
services,
taxa e elevada de malária, por
a
exemplo,
high rate of
quando nos
malaria, high
territórios
prevalence
indígenas
in indigenous territories.
temos a informação ou de coqueluche, por exemplo, mesmo malária em
We
crianças,
see a variety of
porque
diseases,
tem as
parasitosis,
características imunológicas
because they are the immunological features of these
sociais
populations,
dessas
which
populações,
are also social.
além, sim, deles terem uma restrição, né,
In addition, of course,
acesso
to
geográfico, ele é
geographic access restrictions. And the whooping cough is also very
a
prevalent.
vulnerabilidade de ter surtos explosivos,
And
né?
they're also vulnerable to
Como
outbreaks.
nós temos visto e temos acompanhado até inclusive um sucesso do programa
Even
que foi a redução
saw
da
the
taxa
successful program in
de
reducing that,
mortalidade na
reducing the mortality rate
nas áreas
in
de
the
fronteira,
Yanomami
a
territory.
importação e a
In
exportação
border
é
areas, we see
importante,
imports and
a
exports as a
vigilância,
factor.
alerta,
It is
né? A
important
gente
for
está falando
surveillance to be very
de
attentive
malária,
to
mas
that.
chama atenção aqui
Here
para o
we're talking about malaria, but
é um agravo que nos
there are other
acompanha
aspects,
sempre. E um outro ponto que é muito desafiador nas áreas
especially in terms of
para
measles.
quem já trabalhou, é a heterogeneidade não
The
só
heterogeneity, not just of the
mas
protocols
também
and
dos
services,
serviços
is
de
very
saúde
important.
para o acolhimento desses indivíduos.
And another scenario which is important is the urban areas. And here I include arboviruses and the outbreaks of arboviruses. These will heavily impact the overload of health services.
O viajante na Amazônia não é o turista.
Amazon travelers are not tourists. Tourists are a very low percentage. These are the individuals who move around due to their work, be it for mining, for building projects. Like I said, the riverine population, which moves around within their own municipality to study, to work. The movement of the indigenous populations, the eco-tourists, commuters, and us researchers as well, who go to these endemic areas to work, to conduct our studies, to apply tests, collect samples, and I have a lot of experience in providing services to our colleagues, to the members of our teams who get malaria and co-infections like dengue. These are also underrepresented here. And to just remind you that these travelers have this feature of taking and bringing. And we have several examples here to mention. Professor Marcos will remember the chikungunya fever, which took place in the traveler camp in Ribas, where we saw the first cases in Brazil. It's important because these also alert surveillance agents to what is silent or otherwise. And what we see, which is also very important for us to reflect on, is febrile syndrome within that spectrum. Within the context of the expansion of these agents, the circulation of myata, for example, oroposhi as well, the climatic impact. We've been hearing about this for 30 years, and we are seeing these changes in real time. The repercussions are very real. The southern floods were extremely consequential. We see a lot of social economic issues, of course, but there were also many health-related issues, especially in terms of leptospirosis. I always say that we have to speak, think, and practice the obvious. So in terms of a febrile syndrome, and I tell this to my students, in the Amazon, the first hypothesis, the first and last, is malaria. The first disease that will be investigated. It is non-negotiable. But alongside it, it is also important for us to evaluate the patient history, evaluate their mobility, how long they remain in that territory, and what they develop. We clearly see that service integration, so from health services, clinics, surveillance agents, and laboratories, the integration between all of these is extremely important for us to have a higher degree of transmission control. And this is something we've seen in malaria. I'd like to thank Professor Marta for this slide. She's responsible for this study. And this is mainly to talk about the importance of investigating fever in non-malarial cases. This is the Franklin Simon study, our dear friend. And recently, he diagnosed 3 cases of encephalitis, the Venezuelan viral case, exactly in the border between Brazil and Tabatinga, Brazil, Colombia, and Peru. Once again, the importance of syndrome surveillance in the
E é
Amazon region.
importante porque já imaginou se sai, que a gente comentou logo no início, né, que é uma
And
característica
as we
da
said in the beginning,
Amazônia, a sobreposição
it is an
dos
Amazon
ciclos
feature,
silvestres e
the
urbanos.
overlap of the
Então,
urban
quando
and
isso
forest
acontece,
cycles,
realmente acende o
with,
alerta para toda a
as is
rede
the
que
case,
está
as it is the
atenta a
case,
compartilhar as
the surveillance
ferramentas de
network needs to be
diagnóstico
attentive and
para
share the diagnosis
controlar
tools in order to actually
situações
have some
de
degree
agravo
of
que têm
control.
impacto em saúde pública.
This has a huge impact in public health.
Trazer esse estudo que
I also wanted to include this study
dos nossos colegas da Amazônia
by our friends from the Peruvian Amazon.
com pouco tempo. E
As time is short, I won't go into too much detail.
uma ferramenta diagnóstica
They developed a diagnosis tool
diagnóstico de
in order to conduct the diagnosis of
um
various pathogens.
protocolo, mas eles têm
For now, it is a protocol, and they have been using it
sítios que eles iniciaram
in the sites where they began these studies.
resultados tanto do ponto de vista de
They've had good results in terms of epidemiological surveillance
assistência.
as well as in health services.
Por que que a Amazônia ela
So,
diferente, ela é
why is the Amazon
acaba
different?
sendo uma singularidade, muito pelo
Why is it
que
so
nós
singular?
falamos anteriormente, pela sua diversidade
Also because of its
biológica,
biological diversity, as we mentioned earlier,
densidade de agentes infecciosos
due to the high prevalence of infectious agents,
conhecidos ainda para nós, uma alta,
emerging and descending, known and unknown, a high degree of human mobility,
principalmente os internos. Então,
especially
eu vou falar,
internal.
mas tenho certeza que vocês sabem,
I won't mention them, but I know you know this. In Amazon cities,
principalmente nas capitais, nós não temos
especially in the capital
os
cities,
alunos
there's no
dos
malaria.
cursos de saúde terminam o curso sem ver
So the students who study there usually finish their courses without seeing malaria.
eles não veem malária também. E as características também do risco zoonótico,
And the features of the zoonotic risks.
característica também desse grande bioma da Amazônia
It is a
essa
feature of this biome.
ciclos silvestres
The overlap of the urban and forest cycles
região.
within the region.
Outro ponto que também é muito
And another point that is very important and that we are discussing here is the limitation of access to services.
avançar. Eu trouxe essa
We also have to advance on that. I brought this image here, which was an announcement of the World Health Organization with an agenda to have these tools used in the big centers and laboratories by 2032, advancing into the areas that need diagnosis and control of important diseases. And I would like to remind you that no diagnostics tool will be the savior. It is just going to add to the necessary toolbox for the identification of these agents. And here I would like to introduce to you our initiative at the Evandro Chagas Institute. We started a traveler health clinic, which is another piece of the puzzle to contribute to epidemiological surveillance and the assistance of people that are traveling. In the service, we assist them before, during, and after their trips. This is still in the beginning. We started this clinic during COP30. And this is us from the team. Thank you very much for your attention. And thank you to Gisele, Natalia. I'm not in this photo because I was in Sao Paulo doing my postdoc, but it is a huge joy to be with them. And I say that I'm almost an outcast because the girls, they belong to the laboratory and I am the practitioner in the group, but I feel honored by being included. Thank you very much for your attention.
Oi, oi. Muito obrigado, professora Tânia. Professora Aniele, fique à vontade.
Thank you, Professor Tanya. Professor Aniele, the floor is yours.
Bom, boa tarde a todos, bom dia, na
Good
verdade.
afternoon, good evening, good morning, actually, everyone. I would like to thank Wanderson, Carol, Danielle, everybody who is here in the Congress. I would like to say it's an honor to be here to talk about the extra Amazon region. I will talk about the integrated surveillance of acute febrile diseases in the extra Amazon region. And I would like to say that most of what I'm going to say here comes from a long learning process since 2017, in an effort coordinated by Professor Patrícia Brasil, with a follow-up of travelers that have acute febrile illnesses. And I'm going to show you our experience today, speaking of the importance of malaria, but also the importance of the syndrome diagnosis, thinking about other causes of fever, especially in people who are returning from an area that is endemic to malaria. To contextualize, I know that you heard a lot about this throughout these 3 days, but so we can think about the extra Amazon region. I'm going to be repetitive, but I think it's important for us to fixate this idea throughout the presentation that 99% of the autochthonous cases of malaria in Brazil are concentrated in the Amazon region with high volume, continuous transmission, and consolidated suspicion protocols. This is an important point.
Doutora Tânia mencionou.
Dr. Tanya mentioned it, and Dr. Claudia always says that even the doorman of the basic healthcare unit is capable of thinking about malaria as the diagnosis of a febrile patient. People inserted in this context, they always think about malaria as a diagnostics hypothesis. When we look outside the Amazon, we're looking at the blind spot. We have 1% of the cases notified in Brazil happening and being notified outside of the Amazon region. And that is where the problem starts, those who are not seen or not remembered. So during the training of the healthcare professionals, they don't understand malaria as an important cause of fever for an individual that returned from the Amazon region. Patient may say, I think I have malaria, and the professionals don't even know what exams they should, what tests they should request. They request serology to know if the person has malaria. So this paradox brings what is most important to us when we think about the context of elimination, which is the reduction of the lethality of malaria. There are more deaths outside of the Amazon due to malaria because of lack of knowledge. So this disproportional lethality is what draws our attention outside of the Amazon region. I talk about the imported cases, but I also can talk about the autochthonous cases that happen in the rainforest regions that have even more complicated diagnosis because of this absence of clinical suspicion. The golden rule when we are outside the Amazon is that malaria is a disease of compulsory and immediate notification. Suspicions of malaria should be notified in up to 24 hours after the onset of symptoms, so that we can be very fast. We can initiate the process of diagnosis, which is not that simple, differently than in the Amazon region, where you have diagnostic tools in all of the healthcare facilities. Outside the Amazon, it is concentrated only in a few units, and so that we can contain the malaria introduced in these regions. Pretty much all of the national territory has anopheles. So one case introduced in a location may generate secondary cases. Last night, after the presentation of Todos pela Saúde, I changed my presentation because I thought your lecture was amazing, and I analyzed the lethality of malaria outside the region. Bahia has death by malaria. Mother and daughter in the south of Minas died after a trip to Africa. São Pedro, here in the state of São Paulo, has one death. uh, by malaria. Patient dies with suspicion of malaria in the countryside of Minas, returning from Africa. This is a case that I always mention of a Brazilian diplomat that contracted malaria in Africa and died of malaria in Brasilia. In Venceslau Guimarães, an outbreak of malaria has one death. I will talk about Malaria Phone, which is a hotline by Fiocruz. But whenever I have a suspicion of malaria that I talk to the ministry, I'm always in a rush. So I would like to show here so everybody knows of the commitment of the whole malaria team. I exchanged a lot of messages with Dr. Tanya saying there's suspicious cases somewhere. I text Hona and Dr. Tanya at on Saturday at 7 a.m. or on Sunday night because we know that people need to know about it. So we try to warn them as fast as possible. We try to inform about the test that the patient should go through and what they should do if it is positive. That's just to show you the importance of having people there listening to what the experts are saying. And this delay in diagnosis, in addition to resulting in death, because they take a long time to search for healthcare facilities, and it also generates outbreaks introduced in the receiving locations. I brought the outbreak in Espírito Santo in Vila Pavão after an introduced case. Dr. Garazielli and her team went there, and more recently we had an outbreak in Bahia, in the city of Venceslau Guimarães, and it even achieved Caraíva and Trancoso, very touristic cities, due to this delay in notification. This individual remained with a febrile syndrome in that location for a long time. The vector took the disease to other individuals, and we had a transmission cycle at that location. The lack of clinical suspicion resulted in deaths, but also resulted in this dispersion of the malaria cases in this region. So something we should discuss is that very rarely this test is done in the ER. So we should analyze the anamnesis of this individual that goes to an ER. Does anybody ask if they traveled, how long they traveled, where they traveled, what precaution measures that they used? Tanya's speech is perfect in this sense because people only think about malaria when someone traveled to Belém. If they went to COP 30 and they have a fever, but did they stay in the city? Did they visit the Riverside community? Did they stay in the hotel? Every day we have people who are going to travel to Manaus and they ask if they need to do chemoprophylaxis. We asked them if they stayed in the city of Manaus or if they went to the countryside. So, because people just don't know about the epidemiology of the disease. I'm going to bring some data of the malaria elimination national plan. I participated in the first draft with Dr. Claudio. And in 2022, we had about 129,000 cases. Now in 2025, 120,000 cases. And we have as a goal for next year 41,200 cases. I don't want to be pessimistic, but I think unfortunately we're not going to reach this goal. In 2030, 4 years from now, right around the corner, we want to zero the number of deaths by malaria and eliminate the transmission by Plasmodium falciparum. When we talk about eliminating the elimination through P. falciparum, we're talking about the Amazon region and the hot spots. But when we talk about zeroing the number of deaths by malaria, I am also including the regions outside the Amazon. The deaths by malaria happen in most of the cases outside the Amazon, and we have 4 years to zero them. In the elevator this morning, I asked Alex, how many deaths did we have last year? 39. So we have 4 years to zero the number of cases of death to achieve this goal. And I think the negotiable pillar for us to achieve the goals of the elimination program is to have a strict control of the reintroduction of malaria in the regions outside the Amazon, of these small outbreaks that happen. And we have to focus on the phase 3 of the plan from 2030 to 2035 and on the interruption of total interruption of the transmission. But when we zero the transmission or reduce the transmission significantly, are we going to be training professionals that are going to think about malaria as a diagnostics for a febrile patient? So after elimination, we should think about preventing the reintroduction, but we should also train these professionals. Speaking of what we have called pressure cooker, which is the illegal mining and the borders and the Yanomami territory, the pressure that the parasite is suffering there, what we have to think about, and what Dr. Tanya mentioned, is the concentration of malaria in this region that is very much related to illegal mining. We talk not only about mining, but mining-related activities. People travel a lot with mining-related activities, so they may arrive in Rio de Janeiro or in São Paulo or Espírito Santo with malaria, and maybe a malaria with a degree of resistance or a parasite that does not respond to medication. So this is what we have to think about too. When we look at the border area, including the non-malaric malaria febrile syndromes, we have to understand that measles re-entered the country through Pacaraima, and we have this border and this intense populational displacement in the border region. That's what we have to think about. Fast mobilization of big populational groups that are circulating and are going everywhere. We had a patient from the Rocinha favela that went to the Goianese Institute because they said that he would make more money there than with the drug trafficking. So he came back to Rocinha and he came back with malaria. So it is very important to understand how they move around. And thinking about these people that travel a lot, I would like to bring you an example because we always talk about mining or tourists, but I would like to mention the example of military officers. They are being displaced all the time. They go to missions in border regions or in the jungle and they return with malaria. Every month we have a military officer returning from an assignment, and they are groups that are very susceptible to returning sick because they're very exposed. What we have tried to do is to communicate with these teams, or at least with those who are here in the base. If the officer returns with a fever, they need to look for a treatment, having malaria as a possibility. Dr. Tanya already mentioned the importance of traveling medicine, and I would like to talk to you about some of the programs that we have that are free, like Emílio Ribas with online scheduling of appointments, CIVUS from the Federal University of Rio, and CRI, which is a pre-travel outpatient clinic. And I'll talk now about what we see in our outpatient clinic, which is the post-travel scenario. The patient arrives with a fever for under 7 days, and we triage them according to the syndrome that they might have. Icterohemorrhagic syndromes, neurological, acute diarrhea syndrome, or acute respiratory syndrome, or exentemathic. We kind of make a triage of this patient according to this criteria. When we talk about malaria, we have the worst enemy for patients, which is the viral overlapping, which brings to us a zone of clinical confusion. I learned this term remaining diseases in a class, and among these remaining diseases, we have here malaria, wild yellow fever, Zika, and chikungunya, when we think about other areas.
Bem carioca no final. Mas aí a gente entra no que a gente chama de uma neblina diagnóstica, né?
And we have what we call a diagnostics haze. A febrile traveler arrived in São Paulo coming from the countryside of the Amazon. They might have any of these pathogens that I mentioned, but what we have to think about is that all diagnoses have to start with the immediate and compulsory exclusion of malaria. I can think about all of these options, but I have to exclude malaria. Speaking of this diagnostics labyrinth, thinking about malaria, dengue, leptospirosis, yellow fever, and maculous fever, first, I will think, what is the kind of exposure? Where did this individual go? If I think about leptospirosis, were they exposed to rain or the cleaning of a region after the rain? Did they have any kind of wild exposure? Do they have vaccine for yellow fever? Were they exposed to um, were they exposed to spotted fever, maybe in contact with ticks? We have dengue from 0.06 to 4.4%, leptospirosis from 9 to 10%, and spotted fever 34%. 2 weeks ago, a patient died of spotted fever. It was a dear patient to us, and he died of spotted fever because of exposure to ticks. So where I'm saying we have to think about malaria, we have to think about malaria for a patient that returns from an endemic area, but I would like to give you an example of Espírito Santo, thinking about epidemiological noise. Espírito Santo recorded in 2023 an increase of more than 1,000% of probable cases of dengue. So how am I going to suspect of malaria in an ER that is full of dengue? That we can't think about malaria as a diagnostics hypothesis. So the assistance is directed to dengue. Everything is dengue. In Rio, everything is dengue. They only think about malaria after the patient is feeling very bad. Someone says that it's important to think about malaria.
So about the movement of yellow fever, it's reaching endemic areas. We're coming from very relevant regions with over 2,200 animals confirmed, non-human primates infected. And if we include a larger period, we see 279 deaths due to yellow fever, a lethality rate of almost 35%. Yesterday, I was checking data. In the state of São Paulo, up to April 26, has confirmed 26 deaths. Well, 26 cases and 3 deaths, actually. So the state is requesting the population to vaccinate after these cases. And the yellow fever vaccine is mandatory, regardless of the location. So again, São Paulo government calls population to vaccinate. And also to bring it to my side, we just published a paper showing that the cases of yellow fever reduced the cases of malaria in the Atlantic forest of Rio de Janeiro. And coming back to the first day, we were mentioning the non-human hosts. If we have an episode that kills all the primates of that region, you reduce the host, and therefore you reduce the number of cases of malaria. And if you think about one health, one disease impacting the other. Coming to a close, the silent threats, so leptospirosis and spotted fever, an incidence of about 10% lethality post-pandemic for leptospirosis, 34% for spotted fever. The data also shows that last year we had 164 deaths due to leptospirosis, with an estimate of 200 to 300 deaths. So almost 10, you die 10 times more due to leptospirosis than malaria. 40 to 60 deaths due to spotted fever as well. This data was not yet consolidated for us to reach the final number. So the abrupt onset acute fevers, they do not forgive lateness in introducing treatment. So briefly on Oropuxa and Mayaro, I won't go into too much detail in Oropuxa, but for Mayaro we had a very quick expansion in terms of AROV from 2023 to 2025. From the official data of the ministry, almost 20,000 confirmed cases for 6 deaths. In 2024, we saw this very quick outbreak, epidemiologically speaking. 2025, we maintained the high transmission and increasing gravity. And in 2026, we're trying to understand what happened. It seemed like it disappeared, but did it actually? I was talking to Vanderson, and he says that maybe it was always in place, and now that we put on our glasses, we're able to observe. And we have Mayaro, which we don't diagnose as much, but it is a threat because of the risk of transmission. So in terms of One Health, very quickly, we have to think about the fact that the patients in the ICUs who have a fever, they're not beginning a cycle. They are the end of a cycle that begins with surveillance, environmental, epidemiological, and laboratorial surveillance. Strategic imperatives. So active genomic surveillance, as it was mentioned by Venderson and Dr. Tanya, a strengthening of digital health, and transborder intelligence. Also malaria phone, which is dedicated support to malaria. It was analyzed by, not by me, but it is a clinical support for malaria in Brazil. We have digital support provided by healthcare professionals to any individual. It is national, so it's basically a phone number that people can contact. We provide instructions about places where they can go to access treatment. The absolute focus on diagnosis and clinical security to be a basis of treatment. There's no empirical treatment for malaria in Brazil. So, oh, hold on, let's get a venous artesunate. Let's begin with oral. We do this a lot with the people at the ministry. We've been going through the challenge of restructuring of our health service. So from 2020 to 2023, we saw a huge crisis with the destructuring of local and even general health services at the federal level, a drastic reduction in health stations, and a data blackout. Now we need to rebuild our diagnosis base, not just where we have transmission, but especially in the areas where we have a higher risk of finding patients with the acute febrile illnesses. SUS is amazing, our single health system. There are challenges, but we need to think about the elimination of malaria as far as 2030. It will also depend on the extra Amazon region, especially in terms of deaths. And in terms of integrated surveillance, I don't mean just the disease, I include the territory. This is the malaria phone contact. Please feel free to get in touch. But actually, when you have a question, don't call just to ask if it works. It does work. After presentations, usually people just send messages, oh, just to know if it works. It does work. It's just me, so sometimes it takes a while. Send a WhatsApp. It's always much quicker. And whenever you can also help. I have a network of people who are around me who I ask for help when I don't know the answer to something. Thank you. Thank you, Professor Aniele, Professor Tanya, for the excellent presentations. I know that we are slightly late, but I will open for some questions. I have a few questions. But before anything else, I said I wasn't going to thank anyone specifically, but I think we must thank one person who was very important for the public health of Brazil, Professor Amilcar Tanuri, who has left us the past year.
Bom, então eu abro para
All right,
perguntas.
so if you have any questions.
Parabenizar o evento e a mesa, doutora
Thank you
Tânia.
for the presentations, Dr. Tanya and Dr. Nieli. It is always a pleasure to hear from you. I'd just like to make a comment on something that Tanya mentioned on the investigation of acute febrile illnesses. It can't be just clinical, it is epidemiological and territorial. And when we reach the extra Amazon region, this becomes extra evident. Just to stress what Daniele mentioned, I think it's worth hammering on. It must reach the health authorities. There are many things that do need to change, even before the genomic surveillance, because these are simple things that must be changed. The extra Amazon region has a lethality that is 50 times higher in malaria. And this includes children who come with a fever coming from Africa on a Friday on a 7 p.m. at 7 p.m. and they get to a hospital where they only treat adults, where diagnosis is only provided to adults, and doctors who think about malaria, they don't have a place to diagnose malaria. So two very important things that need to be stressed. Thinking about malaria and provide the tools for people to diagnose malaria. It's not enough for us to think about malaria and just say, oh, okay, what do I do, Aniele? To the point of us getting requests to call malaria phone. So these are things that are unbelievable, and it always happens, especially during weekends, holidays, where there's no one there. And this is also very important for the private networks. It needs to be looked at very closely. Doctors there don't usually think about malaria. And even if they do, they are often unaware of how to diagnose. So I want to mention the decentralization of malaria diagnosis. I was looking at the hemogram device. It may be a path or maybe one more tool for you to add to the public health stations. Maybe tell the security guards, oh, if you see a patient from Africa, go take them to the beginning of the line because malaria kills. And if you don't treat it quickly, the patient will die. You have to treat the falciparum up to 24 to 48 hours. And we've seen a lot of deaths because of this. And having the tools. So I imagine throughout Brazil where we don't see malaria, where we're not thinking about it. And when we think about it, you can't diagnose. So it's really this gradual work of training, clarifying it to the population. Let's go to the health stations and tell people to be attentive towards people who are coming from the Amazon and from Africa. Thank you. Just to complement what Professor Patricia mentioned, this reality is something that we also see in the Amazon. In Belém, our reality is not different. Malaria is in rural regions, and the doctors who finish their courses, they don't usually see malaria, very rarely. So my proposal, this fusion of the clinical perspective with epidemiological surveillance and the clinical side focused on this crucial point, which is the investigation of mobility, I see this as essential for this integrated surveillance. so we don't have surveillance that is always running after things that it left behind. We don't want reactive surveillance. We want active surveillance. And what concerns me deeply is, well, I'll put it this way. This issue that is ours is something that we've been talking about for a very long time. And I wonder, how can we still trailblaze further? How can we move this needle with the state and municipal levels so that we can push this forward? In Belém, we've been doing a lot of work and we're really receptive. I'm very close to the surveillance agents. We exchange information. We provide training. We take training. It can be in person. It can be virtual. I tell them, you can call me anytime. I think it's along those lines, strengthening the integration of services and of the various surveillances. Thank you.
Bom, como ninguém se manifestou, eu tenho uma pergunta.
Well, as there are no questions, I have a question for both. I remember the time when Zika came to Brazil, I was working in surveillance, and the clinical profile changed from the origin to here. What we saw in Brazil was a light fever, or even the absence of fever and some light symptoms. And at the time, we treated Zika as a light dengue. It was harmless. And it very much was not harmless. And my concern is that whether we're not addressing Oroposhi as we treated Zika in the past. Oh, there's a virus here that causes encephalitis. Aren't we treating other viruses like this due to the absence of these lenses? I think the Dr. Patricia's laboratorial experience is very interesting. When we saw the first Oropushi cases, we understood that it was important for us to follow them, follow the cases. In most studies, we see that the patient is treated, diagnosis, and moved on. We have a study in which we followed these individuals for a longer time, exactly to try to provide answers to the questions that you made. In Zika, we thought it was fine. So Professor Patricia has a cohort that she's following so we can better understand how these pregnant women who were exposed behave. We try to understand whether there will be more neurological repercussions to these individuals. So we're trying. We're always very fearful to provide that information as final results, because we know that in the beginning we have that initial format and we don't usually have the time. We just have a frame, not the picture. We intend to have the full picture, not just one frame. Follow them up, understand the clinical framework. We have a huge questionnaire that we use. Often people are not even aware that they're feeling that. So the epidemiological and clinical features are extremely important for us to understand that at the medium-long term, for us to better understand this new old virus. A comment and an altruistic provocation for Professor Patricia. So Zika, or at the time when we were diagnosing, we were alerted to it and to its possible association, or at the time possible association to microencephaly. And Brazil did exceptional work on the laboratorial surveillance. It was amazing. I think Professor Patricia also knows this. So many negative cases, and we can't really help ourselves seeing that movie play again in our minds when seeing the Oroposhi situation. There were many contributions to it. We're always paying attention to microcephaly as an association to otopush. I believe there are 6 to 8 cases. I can't recall the number exactly. 6, yes.
Então, Wanderson, sobre o que
So,
você
Vanderson,
falou, eu
on
acho
what you
que
mentioned,
nós temos que realmente, como eu coloquei,
it's as I said,
pensar, falar e
we must
praticar
think,
essa trilha da
do
investigação
and
junto
practice this trail, this pathway of investigation.
com as
We need to
diferentes
strengthen it
estratégias de
with the various surveillance strategies, clinical, epidemiological, laboratorial.
Acho que tem um ponto importante aí. Quem procura acha,
An
né? Quem
important
não
point here.
procura não
If you look for something, you find
tem que
something,
encontrar e tem que saber
but
correlacionar,
you need to
não ser só
be
um
able to
achismo
find and correlate it.
relacionado com a clínica e com a epidemiologia.
A Carol já me olhou com cara feia, então.
Carol is
Muito obrigado pela presença de
already
vocês.
cutting me off here. Thank you so much for your attention and have a great lunch.
Ah, a Carol mandou avisar que
Oh, Carol's telling me to let you know that we'll have lunch outside and we will return at 2 p.m.